Welcome to the Rural Opioid Prescriber Training provided by SIU School of Medicine and Illinois Department of Human Services Division of Substance Use and Prevention and Recovery, with funding through a grant from the Substance Abuse and Mental Health Services Administration. Today's topic, the Opioid Medication Assisted Treatment Program, will be presented by Ingrid Lopez. Ingrid Lopez is a bilingual, speaking English and Spanish, licensed clinical social worker and a certified alcohol and drug counselor, specializing in treating adults with depression, anxiety, trauma, addiction, stress, and anger management. Ingrid has experience working in an outpatient setting in both behavioral health and substance use treatment centers. She has extensive experience working in the harm reduction field, specifically in medication-assisted treatment programs. Currently, she is the project manager of Sinai Chicago's Opioid Medication Assisted Treatment Referral Program at both Mount Sinai Hospital and Holy Cross Hospital. In the past year, she has worked to improve the program's success, expand the program's network, and was an active member of the initiative to distribute Naloxone kits to medically admitted patients who were identified as opioid dependent. Ingrid, you may begin. Thank you.
Thank you for that introduction. Welcome, everyone. As mentioned, today's presentation will be focused mainly on the program that I manage here in Chicago, but I do want to go ahead and give a little bit of background on opioid use, overdoses, naloxone, prior to touching on my specific program. So, what we'll go ahead and cover today, as mentioned, is on opiates, overdoses, some Chicago data, the various treatment options out there, along with a Chicago hospital system and our approach to address the opiate epidemic. So what are opiates? There are many different opiates out there. Most commonly, pain relievers such as oxycodone, hydrocodone, codeine, morphine. Typically, these medications are prescribed after a major surgery, whether that is a kidney removal or an ACL repair. There's also synthetic opiates such as fentanyl and an illicit drug known as heroin. With any of these, if we take these over a period of time, it can lead to tolerance, it can lead to being diagnosed with opioid use disorder, and it can lead to an overdose. I went ahead and put on the slide the criteria to be diagnosed with an opioid use disorder. The DSM-5 identifies opioid use disorder as a problematic pattern of opioid use that leads to clinically significant impairment or distress. Now, anyone can develop opioid use disorder, whether you were prescribed medication after your ACL repair or whether you were introduced to heroin by a friend. I've had personal friends who have had their ACLs repaired and they took their medication as prescribed. And once their medication was done, they shared the intense withdrawal symptoms that they experienced after 2 or 3 weeks of taking this medication, or however long they were prescribed the medication. They experienced chills and sweats, nausea, diarrhea, body aches. They were in fetal position in their bed. Oftentimes, when that is experienced, individuals' brain wants more because they want to relieve those withdrawal symptoms, right? It's having like a flu times 2 or times 5. So again, that goes ahead and leads to that dependence, to wanting and craving more. Well, if we continue to seek out more medication, we at times start to take more than we're supposed to, leading to overdoses. What we've seen is a rise here in America with overdoses. Between 1999 and 2019, the CDC reports that we had nearly 500,000 opiate overdoses. I like this little picture here just because it does also share how it's kind of progressed. In the early 90s, it was prescription opiate overdose were skyrocketing. In 2010, we saw more heroin overdoses. In 2013, we saw the spike in fentanyl overdoses. So individuals were either using fentanyl or they were using heroin that had just even a tiny bit of fentanyl was leading to an overdose. So what is an overdose? An overdose is when our respiration is suppressed or when we may stop breathing. What leads to an overdose? If we start taking more opiates than we're prescribed. So if we're supposed to take our medication, one Vicodin every 6 hours, but we choose to take 4 Vicodins. After taking it consistently one every 6 hours, our body can't handle that. It's not used to that. If we're combining our prescribed medication or heroin with other depressants like alcohol. So it is highly recommended that everyone is aware and is educating individuals that if you're prescribed this medication, if you're prescribed Vicodin, if you're prescribed morphine, to not use alcohol or benzodiazepines. And then lastly is taking more opiates than one can tolerate. So just being cautious with how much we're taking, when we're taking it. How does an overdose look? An individual will start to not respond, even just by shaking them or saying their name, and not even shouting their name. If they're just saying Ingrid, Ingrid, and there's no response. When you notice that an individual's breathing slows or completely stops, when their lips and fingernails start to turn blue and or gray, and if their skin gets pale or clammy, those are signs of an overdose. So I want to go ahead and specifically share some numbers for Chicago. So the Chicago Department of Public Health went ahead and shared this information. In 2020, we were not only dealing with COVID-19 pandemic, but that pandemic really impacted the opiate epidemic that we were already in. In the first 6 months of 2020, we saw an increase of 60% of opioid-related EMS response calls. We also saw a 55% increase from 2019 of opiate-related deaths. And the communities that were most impacted in 2020 were the South Side and West Side of Chicago. Now in 2021, we can go ahead and say that there was a decrease. As shown here, you can see that there was about a 20% decrease in responses, in calls, and in opiate-related deaths. But again, the same communities were the ones that were impacted, the South Side and the West Side. And so because of that, Illinois and Chicago have been really active in finding harm reduction and spreading it throughout the state for individuals. And so there is Naloxone. What is Naloxone? It is a medication that is designed to reverse the effects of an opiate overdose within minutes. And so there is a program that organizations can apply called the Illinois Drug Overdose Prevention Program. If you get approved, you are then able to distribute naloxone to individuals at your organization. Most recently, they are also providing free naloxone kits. So prior to this, you would have to just purchase your own naloxone, but now they are distributing it for free for each organization. So at my hospitals that I work at, we go ahead and distribute naloxone to any patient that is referred to our program, whether they want our services or not. We started this in December of 2020. In our first month, we distributed 76 patients at one of our hospitals. In 2021, at both of our campuses, we were able to distribute 2,562 naloxone kits. We meet with the patient, we educate them on what this medication is, we provide them a visual training on how to use this, and we identify each item that may be in the kit for them. Now, if your organization is not part of the Illinois Drug Overdose Prevention Program, or if you give Narcan to your patient and they use it, where else can individuals get Narcan? It is available at most pharmacies without a prescription. If a pharmacist is trained on how to educate an individual, they can go ahead and dispense it. Most insurance carriers also cover the cost of naloxone for little to no copay. And something cool that Chicago is doing is that Chicago Public Libraries are providing it for free. So they've identified 9 to 13 libraries where they will have naloxone kits available, and individuals can go ahead and walk in, pick one up, no questions asked, no identification needed, you don't need to sign anything, they're there, which I think is pretty cool. And so how can we administer naloxone? The two most common ways that the medication comes in is in the nasal spray and in the intramuscular. Both have its pros and cons. Intramuscular is cheaper if your organization is trying to purchase it in bulk compared to the nasal spray. I would want to say the intramuscular can be a bit easier in the sense that you just have to put the medicine in an individual's thigh or upper arm. Compared to the nasal spray, you have to make sure that the individual is on their back, that the airway is open, and that can be a bit difficult at times. I went ahead and just provided a couple of steps on how to recognize an overdose and if it's happening, how to administer the Narcan. Each of these medications will come with 2 vials or 2 nasal sprays, because if after 2 or 3 minutes the patient does not respond with the first dose, go ahead and administer the second one. When I talk to patients, I always encourage the patient to carry the naloxone kit on them. Oftentimes they're hesitant to do so because they think Narcan goes with heroin and a police officer is maybe going to arrest me. Narcan is a medicine, and so if an individual is stopped by a police officer, they will not be arrested with it. I also encourage patients to treat their Narcan kit very similarly to an EpiPen. Let others know that you have a Narcan kit. Let them know where it's located in your house or if you have one on you, and make sure that others know how to use it. If I'm overdosing, I am not the one that's going to be administering it to myself. So just making sure to add those little points to individuals. when we are sharing this information with them. Now, additional ways to prevent an overdose. For people with an opiate prescription, take opiates only as prescribed, and remembering to not mix with other prescribed medication or with other drugs and or alcohol. For opioid users and family members, like I just mentioned, know where your Naloxone kit is, know how to administer it. But also, let's consider seeking evidence-based treatment for our current drug use. And so with that, I want to go ahead and transition to what are treatment options? What are harm reduction treatment options? And so for opioid use disorder, of course, we want to promote drug-free. Can you go the abstinent-based route? Of course. And if an individual wants to do that, we will encourage it and support it. But because of this disease, going abstinent can be difficult. And so there is medication-assisted treatment programs out there. And so right here, there is a few medications that do help with opioid use disorder. I already touched on Naloxone, which is on the bottom right. Today, I'm going to mainly focus on methadone and buprenorphine naloxone, also known as Suboxone. So I'm going to go ahead and share a little bit about methadone and Suboxone. At the end of the presentation, feel free to ask more in-depth questions about either medication if you have any. So for methadone, the purpose of methadone is so that the individual no longer experiences those intense withdrawal symptoms or cravings. A concern that I often hear from individuals is, are they going to get high off of methadone? If you're on a stable dose of methadone, you will not get high. You should not be getting high off of it. With methadone, an individual needs to medicate every single day at a clinic. 6 days a week, you have to show up and take your medication. It's like a full-time job, very intense. But methadone will last in an individual's body for about 24 to 36 hours, just depending on the patient's metabolism. If an individual is on a stable dose, it'll allow the person to feel normal and function to address the other aspects of their life. They'll be able to work, they'll be able to pay attention to their family, establish friendships, be part of the community. Methadone is considered to be long-term treatment, and it's ideally recommended for a minimum of 12 months. Now, another point that I hear about methadone is, well, there's people that are on it for 15, 20 years, you know, that they're on that drug for so long. Why? Because it helps them to feel normal and it helps them to function. We want to promote treating methadone maintenance like the medical model, right? If someone is diagnosed with diabetes or high blood pressure, we don't discourage them from being on insulin or high blood pressure for 20 years, right? We encourage it because that keeps them healthy and that keeps them living each day. And that is methadone, right? If they're on it for 15 or 20 years, but they are paying their rent every day, they are part of the community, they're going on vacations, what's wrong with that medication? For Suboxone, so for a person to start Suboxone, it is encouraged that the individual be in withdrawals. If they initiate Suboxone after getting high maybe an hour or two ago, they're actually going to become sicker. So I often hear patients say, oh, I don't like Suboxone, it makes me sick. we have to talk to them and explore, well, tell me how you used it and when you used it. Suboxone helps manage cravings. It protects in blocking the effect of other opiates that may be taken. Similar to methadone, they do have to take it every day, but they take it at home. And instead of liquid, this one is in film or tablet. With methadone, I also mentioned that the individual needs to go to a clinic every day to take their medication. Compared to Suboxone, they go to a clinic weekly or monthly to just refill their prescription. I'm going to swap back to methadone. For methadone, a patient goes every single day, and for them to take bottles home, there's a lot of requirements that need to be met. And it takes about 2 years for an individual to be able to take 26 bottles home. So those differences are huge, and for a lot of patients, they get tired of being on methadone because of how difficult it is to maintain going in every day. Suboxone is recommended for less severe opioid use disorder individuals. If I have a patient who has been using for 2 years and they are only using 1 bag of heroin a day, I may consider Suboxone over methadone, right? Suboxone may be considered less intense than methadone. Now, if I have an IV heroin user who has been using for 2 years, so the same length of time, but they are using 10 bags a day, I may consider methadone over Suboxone. The quantity that they're using, the frequency that they're using is very intense, that Suboxone may not be as effective. Now for Suboxone, there is no defined treatment length, but it can be considered shorter term compared to methadone. Now, to go ahead and transition to my specific program that I work at here in Chicago, my specific program is called the Opioid Medication Assisted Treatment Referral Program. It's a mouthful. We are a grant-based program in which no payment is required for the referral to an outside treatment. My program began in June 2019 at Mount Sinai Hospital, and we expanded to our second hospital, Holy Cross, in January 2021. So what's our purpose? Well, our patients are all in the hospital for a medical condition or a psychiatric condition. So their COPD is acting up, their high blood pressure is out of control, maybe they're suicidal. Once they're here in the hospital, we discover that they also have an opioid use disorder. So that's when my program comes in, and we meet with the patient to explore if they're interested in change and if they want to get referred to a methadone or Suboxone clinic. So our patients are all 18 years and older. They must test positive for opiates. They will be diagnosed with an opioid use disorder or self-report that they use opiates. As mentioned, the majority of our patients are on medical units or on our inpatient psych units. We also have our majority of our referrals coming in from our emergency room department. Here and there, we will get a referral from one of our outpatient clinics, but those are more infrequent. So my team consists of a recovery support specialist, and they are individuals who have lived experience and they're in recovery. The aim of them is to use their life experiences to help others in treatment and in recovery. They ensure patients are supported throughout the whole referral process. Many of us who have been in this field may often get with our patients, you don't know how it is, right? You don't have this experience, right? They may judge us just because of the position that we're in. Well, the recovery support specialist has that opportunity to share, right? That is their actual purpose. Compared to me, when I'm a psychotherapist, I have to maintain my boundaries, right? I've been trained to not share my personal journey or my personal struggles. But again, the purpose of the recovery support specialist is to motivate, encourage, and provide that hope that change is possible. We also have therapists. All of our therapists are certified alcohol and drug counselors. And lastly, we have case managers. So our recovery support specialists are the ones who meet with the patient first. They share their personal stories and they invite them to be linked to an outpatient program if they choose to. If they agree, then our therapist will meet with the patient, complete an assessment, screen the patient's severity, and provide a recommendation for inpatient or outpatient with a MAT component. They also provide brief intervention. And then the last component is our case managers. Our case managers do all the back end work. They begin the linkage process. They'll look for, when is the patient going to be discharged from the hospital? When is a MAT clinic? What appointments do the MAT clinics have available? They are taking into consideration the patient's insurance, the patient's home address, trying to find, what's the closest clinic for them. We really try to complete all the back end work for the patients. The patients that we serve are in the hospital. They're in at times in pretty bad shape. And so we want to remove that stressor for them. We also provide transportation to their first appointment if it's needed. I included some of the some of the organizations that we work with. One of our big projects over the past year has been building our resources. So in Chicago, we have a pretty good handle of what services are out there, but the further and further you get away from Chicago, the less services that are available. Now, as mentioned earlier in the presentation, methadone, you need to be present in person to get that medication at a clinic, right? Once you're discharged from the hospital, if your appointment for methadone is 2 or 3 days after your discharge date, you will not have any medication available to you. Now for Suboxone, if your appointment is 2 or 3 days after you're discharged from the hospital, our medical providers can help us. We can consult with our medical providers to see if they're willing to provide a 2 to 3 day prescription of Suboxone. So there is no break in treatment. If our patient was in the hospital for 4 or 5 days and they were on Suboxone, they get discharged today and their appointment at their Suboxone clinic is on Monday, we don't want them to break that treatment that they've already had, right? And so consulting with the provider, letting them know they have an appointment on Monday, is there any way that you can provide 2 or 3 days worth of Suboxone for them? So that's been one of our little projects as well here at Sinai Chicago, is really collaborating more with our medical providers if and when we have an appointment scheduled for them. I want to go ahead and share some personal data from our program. During our first quarter, we received 854 referrals to our program, whether that's in the emergency room, that is in a medical unit, or in one of our psych units. From there, 192 agreed to our program. So that's a big reduction, right? From 854 to 192. And the factors contributing to that is at times patients are already in a treatment program. They're not ready for change. They refuse our services, and that's okay. We'll continue to check in on them every time we get a new referral during a different admission. They may change their mind. And other times they're discharged prior to our program making contact. So my program right now runs Monday through Friday during regular business hours, 8 to 5. On the weekends, we do get a lot of referrals through the emergency room. On Monday, when we come in, we go ahead and follow up with all those referrals, but unfortunately at times, there's no contact information. There's no phone number. And so we do end up missing those patients. Well, from 192, we went ahead and referred 152 patients during our first quarter. And then 122 went to their first appointment. Now, 122 is definitely improvement compared to our earlier years when our program first started. But I want to go ahead and share that a main reason why that number at times is low is because it's not a true warm handoff. For me, ideally, I would want, if the patient gets discharged from the hospital today at 12 o'clock, I would want their Suboxone program to be for today at 2 o'clock, right? I want to take them from the hospital to their Suboxone appointment. But that is rarely, if ever, the case. It is typically scheduled for the next day or 3 days later or a week later. And that gap leads our patients to change their mind, to forget about it, and yeah. And lastly, I want to go ahead and share this new initiative that the Chicago Department of Public Health has, is that they have began to distribute free fentanyl test strips to organizations with the hope that we can distribute it to patients or individuals. And so oftentimes when we hear fentanyl, we assume that fentanyl is only going to be in heroin, but fentanyl is being laced in many different types of drugs. We can find it in cocaine, we can find it in methamphetamine, we can find it in pills. So another way of harm reduction is educating patients on, if you're gonna use, you're gonna use, but how can we still be safe with it, right? So prior to using your bag of heroin, can you test the heroin to make sure that there isn't any fentanyl, right? If there is, hopefully you can reconsider using that bag, right? Or now you know that that dealer that you got it from is putting fentanyl in his heroin. So that's just a little picture of what the kit contains. It has little ketchup cups, water, and then it has the test strips. But really the most important part is the test strip. If the patient loses any of these items, again, you can use any cup, any type of water. Again, the most important part is the test strip. And with that, I will open it up to questions.
Okay, we have 2 questions in the queue. The first is, why 6 days for Suboxone and not 7?
What do you mean 6 days and not 7? Why not prescribe 7 days worth of Suboxone?
I will wait for a follow-up to further explain that question.
That was my understanding of it.
If that is the question, what I will go ahead and say, again, what we're asking the medical providers to do is prescribe the amount of medication until they get to their first appointment. So again, if their appointment is 7 days away, asking the provider if they'll provide 7 days of Suboxone.
And then the second question is, what do you think can be done to help people to keep those first appointments?
I would say reducing the delay in getting those appointments. So if you're discharged today, not having it be 7 days away. We are also, on my end, on my team, I have our recovery support specialist trying to give appointment reminders, either the day before. We try to provide transportation, so trying to eliminate those barriers. But if you guys have ideas, I will welcome them because we are brainstorming over here.
Do we have any other questions?
There is a hand raised. An anonymous attendee said, "Thank you so much, an informative presentation." And I'm not quite sure what to do with the hand raise.
And Brent, is there any way that you can type your question into the Q&A or into the chat?
Oh, he's having a hard time with Q&A. I'll promote him to panelist and then he can ask the question.
Can you hear me?
Yes, we can.
Oh, good. Okay. I was starting to type, but I'm not the fastest typer. I have multiple questions. So, one question I had is, kind of relates to the last question with, how many days we're subscribing, and that there is a difference between methadone and Suboxone prescribing as far as how much you take home. Does your agency, or do you know of other agencies having contingency plans for emergencies? Like, if there was to be a local emergency that shut down business, like say a simple snowstorm, is there contingency management for these people so they're not left out in the cold?
So if I'm understanding your question correctly, if someone is already enrolled and established at a methadone clinic, if there are snowstorms, or those types of emergency, any type of emergency, they do plan ahead and will, at a one-time basis, provide an additional bottle of methadone for them. So they have to go in 6 days a week, Monday through Saturday. Everyone gets a take-home bottle for Sunday. So that already is in place. And so for those snowstorms that do come up, they go ahead and provide an additional bottle. Also, methadone does last pretty long in an individual's body. So again, not ideal, but if they do miss a dose, hopefully it'll last them to the following day, right? Again, not ideal. We want them to get on a schedule. We want them to be consistent, but it does last in the individual's body for a pretty long time.
I've got more questions.
Go for it.
Okay, so when talking about methadone and Suboxone, if someone is a heavy user, so maybe they're more likely to get prescribed methadone by their provider. Once they're stabilized on that, is there any encouragement to switch over to Suboxone? And then, in addition to that, do you see any increased uptake in the sub-Q form of Suboxone within your practice, being like, Sublocade, anything that's injectable form that lasts a month versus daily dosing?
So for your first one, switching from methadone to Suboxone, if you're at a dose of methadone, let's say at 60 milligrams, which is a pretty average dose, you'd actually, to transition to Suboxone, you're going to have to detox completely off of methadone And you're going to want to do that at a slow rate because the individual's body is going to feel it. And then to switch from methadone to Suboxone, you have to be off of methadone then for about 7 to 10 days. So I wouldn't encourage it. If you're stable on methadone, let's get you stable. And then let's detox you off of methadone slowly so your body is able to adjust. And once you're off of it, then let's try to live an abstinent life. Right? But there is that difficulty to switch from one drug to the other, or from one medication to the other. There has to be a period of clean time to fully get rid of the medication. Now, doing Sublocade or Vivitrol, those are out there. And if the candidate is appropriate, we would definitely connect the patient. A lot of the clinics that we work with also offer Vivitrol and Sublocade. The only thing with that is that with the population that we serve and the severity of their addiction, it is difficult for them to meet criteria for it. So for example, Vivitrol, you have to be off of all opiates, including medication, for 7 to 10 days. So if our patients are medically hospitalized for whatever condition, they may not be receiving methadone, Suboxone, and they're not using heroin, but based on their medical condition, maybe they're being prescribed an opiate medication. And so they wouldn't qualify for Vivitrol.
Excellent. Thank you so much.
Of course.
Okay, do we have any other questions?
I could ask one more.
Okay.
So, sometimes we're down here in Southern Illinois at SIU, and sometimes it feels like, our drug treatment moves a step behind places like Chicago. And I was wondering, what the atmosphere up there for people in treatment for opioid use disorder who are getting MAR or MAT therapy, how they deal with the participants using other drugs, such as cannabis or methamphetamine. Down here, we know that people can be penalized for this a little bit. And, we're working on the stigma around this area. Just wonder if you think that Chicago is a step ahead with this.
I would agree. I think many would still want individuals to be fully abstinent based on the severity of their addiction with heroin or with any type of opiates. Now, MAR programs, so actual methadone clinics or Suboxone programs, will penalize individuals if they do come up positive during their urine screens. So for methadone, they will have random drug screens on an almost monthly basis. And if they test positive for if they test positive for marijuana, it'll be addressed and reviewed, and it will then make it difficult for them to have take-home bottles of their medication. So when I worked at a methadone clinic, I would have patients who were picking up 2 weeks worth of medication, and they might have smoked marijuana, and they had to start coming back 6 days a week. And that's a drastic change, right? For them, they are so proud of being able to only come in twice a month into the clinic to then have to come back 6 days a week. So it's still there. And I think it's a bigger problem with the state regulations behind this medication and how you need to be demonstrating this to then be eligible for that.
Thank you so much.
Okay, well, I don't see any further questions. Ingrid, can you stop sharing your screen? And then I just want to say thank you so much for all of your time and sharing your valuable information and insight into medication-assisted treatment today. We really appreciate it. And for our attendees, as always, thank you for your attendance. In order to receive credit, you can either use the QR code on the screen, or I have also included a link in the chat as well. So thank you. This concludes our presentation.